My background is in mental health nursing actually, but I've specialised in working with people with personality disorder for about the last 15 years or so. I worked in specialty services in New Zealand before I came to Australia. So well done those who've picked up a New Zealand accent already. It might come through. So I'm really happy to meet with you tonight. Rita asked me, and I was really happy to do this. I'm quite passionate about treatment for people with borderline personality disorder, given it is what I've specialised in for some years now. I find it really rewarding work and work that we can see outcomes in, that I can see outcomes in. I can see changes. I know that I can make a difference, and I think that's what helps me go to work each day, knowing that I can make a difference. It'd be really nice. For me, things are basic actually, and it's just about doing the basics well. So there may be a lot of repetition in this, but I'll try not to bore you with repetition. But please, I like to be interactive in sessions. Please ask questions or jump in or add to anything I'm saying or challenge anything I'm saying as you wish. So Rita asked me, I don't know, a couple of weeks ago to give an outline of the session, and I kind of hadn't had time to think about what I was doing. So she said what people generally seem to be interested in, so I gave an outline of a session that included a lot of that. And then I found I had to do a presentation covering everything that I'd said I'd do. So this is a fairly broad presentation, I think, starting from etiology through to self-care for therapists. But we'll just go through that and just respond, spend more time on the things that you're interested in. The etiology, I think, people are very, very familiar with the idea of biosocial theories. They've been around a long time. I think it's really common sense that there is some mix of the temperamental nature of the child as they're born and the environment that they're growing up in that shapes their personality through time. I will talk a little bit about DBT because it is the model that I'm most familiar with, but it also has a really good theoretical basis, and it has a really good way of explaining the etiology of BPD, I think. So DBT does focus on a biosocial model. They kind of think that there's an inherent fault in the emotion regulation system, or just, not even a fault, but just a sort of a neurological kind of wiring issue in the brain and the limbic system and the linkages with the prefrontal cortex. But that's okay, but if it's combined with an invalidating environment, then problems start to develop. But in DBT it focuses more on not a static state, but the transaction over time. So I was with someone the other day recently who I hadn't met before, a client, and she talked about, I was trying to ask her what she would like out of therapy, because when it's hard, when treatment gets hard or when people lose motivation to come, it's good to be able to remind them why they wanted to come, what they really wanted to change in their lives. And so she said, initially she just said, I wanted to feel better, but then she was able to expand on that and say, I want to be able to have my emotions and be proud of my emotions and not be ashamed of them. And she said that she thought she actually had normal emotions growing up, but that her family didn't allow her to have those emotions. They didn't allow her to express them, and they told her that she was wrong for having those emotions. And she may be right actually, that the emotions she had when she was young was just in a relatively normal range, but if a child has, and no doubt with some sensitivity, some kind of inherent sensitivity, if a child is presenting with a little bit more emotional need than what a parent is able to give, then the parent kind of might reject the child's communication in some way or withdraw from it. And that act of withdrawal or rejection actually increases the child's kind of emotional expression or need or cry for more attention or more help, which further pushes the parent away or makes the parent further reject the child's communication or invalidate the child's communication. So it's not that the child started off with extreme emotions and the parent started off with extreme invalidation. They kind of reciprocally influence each other over time. right? So it kind of makes sense. But I think that thinking about it as an ongoing transactional pattern is quite helpful, because in some ways in therapy, when we're working with people as teenagers or adults, we sort of want to undo that transactional evolution, and we want to be careful about our communications with clients, you know. We might find that we're with a client and you know, we're okay with them when we first meet them, but over time we start to get a bit more annoyed about something, and then we might get a little bit more invalidating or a little bit more non-responsive. So yeah, just to be mindful of that transaction and how that contributes to the client's emotional state escalating over time. And the combination leads to pervasive. You know, it's not about, I mean, I always feel like I need to say this, I'm a parent, and I certainly was not a perfect parent. It's not about a few instances of invalidating your child, it's about a pervasive pattern over time. So the person, the child, the developing child, ends up being vulnerable emotionally and at the same time unable to regulate those emotions. So the woman I was talking about, who I met recently, I was explaining to her, because this is new to her to be talking about her emotions in therapy, I was explaining to her how if the parents don't accept the emotions of the child, or in some way are rejecting them, they told her that you have to toughen up, you're just too emotional, you won't survive in the world if you're that emotional. They weren't actually teaching her how to manage emotions, they weren't comforting and soothing her. They were just kind of saying, stop it, which isn't teaching skills, those kind of natural skills that we need in life. The vulnerability that people can be born with, that's there's nothing wrong in any of this. Do you tend to find that the people you work with if there was a continuum of sensitivity, that they're perhaps more on the sensitive end of the continuum? And that's a trait. I mean, you know, often clinician, like I think of myself as being a little bit more sensitive perhaps than some people. It's a quality that we're born with, and there's nothing wrong with it. It just depends how it interacts with the environment that you're in. But the vulnerability can be manifest in terms of either a high sensitivity to emotions, so that means there's quite a low threshold for responding emotionally. Their reactions can go quite high, so like what might seem like a relatively minor trigger causes a big escalation in emotion. And then there can be a slow return to baseline, which means that the brain takes quite a while to settle that regulation state. For the limbic system, the nervous system, to settle down, and for the brain, the prefrontal cortex, to start to being able to think rationally again. That can be a slow return. Now, any one of these things is all right on their own. You know, if you have any one of these, you can kind of manage emotions and it's okay. You know, I do think of myself as being emotionally sensitive, and I've actually had to acknowledge that in group with clients when I'm doing DBT group with clients, because I will tear up easily. I'll start talking about something sad and I can't help it, I've got tears in my eyes. So, you know, it's quite obvious to them that I have this sensitivity, but fortunately I don't react really highly and I don't take a long time to recover. I just sort of, you know, acknowledge the emotion and then move on, and they can see me. You know, I'm kind of in a way modelling that to the clients. So that's actually a learning thing in itself. So any one of these on their own is okay, yeah.
So with that, would you see a perception that some of the people who present with this might have a perception of resisting to, they want to stay in that hypersensitive state? As a form of comfort, I'm not sure.
As a form of comfort?
Yeah, they want to stay there, or they can't return to the baseline.
They can't. It's not a very comfortable state.
No,
it's actually not. But I think there's probably something in your question that does, yeah, would be, there's something that they're seeking perhaps in some way.
Yeah.
But the way they tend, often it's the way people tend to solve problems. They're not, when they haven't had good role modelling in childhood, they haven't learnt to solve problems very well, and they can solve problems in ways that actually increases their emotional distress.
Yeah.
So I think it's often poor problem solving or poor communication, and it's a combination of other things as well. But that slow return to baseline, it is, they can actually measure it in the brain. They can see how long it takes the brain waves to settle again. Yeah. Sometimes it could be, sometimes there is a behavioural component to that, definitely. And if that's the case, then you'd kind of want to manage it in a different way. But when somebody has a combination of all these things, it makes them uniquely vulnerable, and it's more likely that they would have a serious emotion dysregulation problem and possibly meet criteria for a diagnosis of borderline personality disorder. Does that make sense? Would you see yourselves would you see yourselves as being sensitive sometimes? Emotionally sensitive? And it's a good quality, isn't it? Like it can be, but it can also, this is what I try to say to clients, it's actually a good quality. It makes us more empathic to other people, attune more to other people. So it can actually be a good quality, but it's something that they may need to learn to manage. So the invalidation piece of that equation is, again, like I already said, it's persistent invalidation over time. And invalidation from parents or caregivers can take many forms, can't it? It can be really overt. Well, we know that there's a high incidence of sexual abuse and physical punishment and trauma, but there can be a lot of emotional neglect. There's that on one end of the continuum, and then on the other end of the continuum of invalidation, it's just a mismatch between the emotional needs of the child and the abilities of the parent to meet those needs. Just as I heard Rita explain it last week, a misattunement between the needs of the child and what the parent understands around emotional communications. There's nothing intentional in it. But that mismatch, if it's ongoing, it actually does cause a lot of problems for the child, because they're not developing a sense of, as my client said, she learnt to feel that her emotions were wrong. She was wrong for having them. So if your emotions aren't met in some way or allowed in some way, and you're not supported with them, you start to get a sense that there's something wrong with you, and then you start to kind of do. It really affects your identity developing as a child. And then invalidation can be things like if a child says, "I'm hungry," the parent might say, "You can't be hungry, you just had lunch an hour ago and we're in a hurry, we're just going to get home." It's quite sort of harsh, perhaps really quite strongly invalidating. But another situation of a different sort of invalidation would be if the child said, "I'm hungry, can we stop and go into that shop?" And the parent says, you don't really want that, do you? I mean, I think you're not really hungry. You don't want to go eating cake now. Let's just go home, and I'm going to cook some vegetables for dinner, and I think you'll be much happier with that, won't you? You're not really hungry. But says it in a kind of a sort of a communication that sounds warm and supportive, but actually it's not. It's actually dismissing the child's self-experience, which is equally damaging, isn't it, as having quite harsh critical communication. So invalidation can take various forms, but they can all have quite a debilitating effect on a child's developing sense of identity and ability to manage emotions. So the consequences, I've sort of talked about that. Children don't learn to identify their own emotions, to regulate them, to name them, to trust their own responses as valid, and instead they look to other people for how they should be responding. That's why you see people sometimes not kind of holding their own ideas about things. They'll ask people how to respond to this, but then they might ask somebody else, and they'll be changing their kind of but their responses, the ways they think about things, their outward style, they may be changing that all the time because they're just looking to something else to sort of give them a sense of who they are inside. And of course they actively self-invalidate. They criticise themselves. They can be very harsh on themselves. You know, that person I was talking about before said she thought she was useless, she couldn't do anything right, and she has no ability to say, I did my best, I tried really hard and I did my best. She can't do that. She just goes straight to, I'm useless and everything I do is wrong. So they kind of internalise that invalidation. Resulting experiences, I think that's probably pretty self-explanatory. And associated diagnoses resulting from childhood invalidation.
Can I ask a question about that? I was talking to a client the other day who suggested they're borderline and they're female gender, and they were talking about a gendered sense between BPD and PTSD. Is that a thing that you say something about, or is that in your field?
Well, there is a lot of kind of gender influences on the diagnosis of BPD. It's not usually between BPD and PTSD though. It's usually that people diagnosed, there's a much higher proportion of females diagnosed with BPD, and males are not involved in treatment so much with this diagnosis. The common thought is that a lot of them end up with more external ways of managing their emotional distress, which might be drug taking or aggression or violence, so they often end up more in the prison justice system, whereas women can be more internally acting, and that kind of leads them into a mental health pathway. But there is a big overlap between what's understood to be complex PTSD and borderline personality disorder. And women will often be potentially, there could be potential confusion for women about the difference between complex PTSD and borderline personality disorder, because complex PTSD can arise from repeated trauma throughout childhood, and women are more likely to be exposed to sexual abuse through childhood. But I suppose equally you could say men are more likely in general to be exposed to physical abuse. So men equally can be, you could think of their symptoms as being representative of complex PTSD. Mm. It tends not to be diagnosed so much because it's not recognised as a formal diagnosis in the Diagnostic and Statistical Manual of Diagnoses.
Which one?
The DSM.
No, which is
complex PTSD. Oh, okay. Yeah, it is recognised in some circles. Judith Herman was the woman who developed the diagnosis of complex PTSD and listed a whole lot of criteria that people would need to meet for that diagnosis. When I've worked for many years with largely women with borderline personality, who are diagnosed as having borderline personality disorder. And sometimes I do think that, their pattern might be better represented by a diagnosis of complex PTSD. But the work is in many ways similar, but then there can be differences at certain stages of treatment. So you're nodding your heads over there. You've had some experience with that, have you? Yeah. So that repeated trauma throughout childhood, which we might think of as complex PTSD, also obviously causes emotional dysregulation. It also interferes with sense of identity. It also leads to impulsive actions as a way of managing emotion. It leads to a lot of dissociation, and people can use self-harm as either when they're dissociated or as a way of ending dissociation. Dissociation can also lead to impulsive behaviours. So there's a lot of, there is a lot of overlap in the symptoms. Welcome. Hi. We're going to keep going ahead, but just ask questions at any point. That's you wish. Does that answer that?
Yeah, good, thank you.
Yeah, that's right. And the thing is, often people will have comorbidity of symptoms. It's just borderline personality disorder on its own is actually relatively simple to treat. It actually is, but you usually see it in combination with depression or anxiety or substance use or eating disorder. And then those comorbidities make it really difficult because the person is balancing between either the emotional distress of BPD or the particular cognitions that go with eating disorder, and it's really hard to make progress in either of them, so that's when it gets complicated. So that's kind of a background to the etiology. We've just kind of gone through a quick biosocial theory. Have you had much experience working with borderline personality disorder? Mm-hmm. Yeah, and you? A little bit? Great. So when I introduced this, I said, please ask questions at any stage. Current approaches, well, I'll spend a little bit of, up to now I've talked about the etiology, the kind of biosocial theory and the role of invalidation. And now in terms of treatment, there are a number of really good evidence-based treatments that clinicians can get trained in varying models depending on either what's available, I suppose, or what suits their own personality or their own style or their own background. But also there are kind of general principles. And approaches to treatment now are based on, there's definitely evidence-based basis to treatment, therapeutic, collaborative, developing plans, having goals, but also paying significant attention to the relationships. Also willingness to reflect on our practice and balancing change strategies with validation strategies, but I'll come back to that. So that's kind of a summary of current approaches. And this is just an overview of some of the most common treatments that are particularly developed for borderline personality disorder, or have evidence as working for borderline personality disorder. As I've said, I'm a fan of DBT. At Spectrum, we provide DBT treatment, we provide mentalisation-based treatment, and we also run a psychoanalytic clinic, and they get really good results in that clinic. We were running an ACT program as well, but that's finished at the moment. So through these specialist treatments, there are some common ingredients. It's actually all about the haircut. I just borrowed that slide from our clinical director. So there are many, many common features across different treatments. The reason why we do focus on the common factors is because sometimes people don't have the opportunity to take up a full training in a particular modality, either dialectical behaviour therapy, mentalisation based, or ACT, or one of the other kind of protocoled treatments. And so, but they can still take advantage of the principles that work. Sometimes it's because services aren't able to fund training for a large group of staff, or there are other reasons why we can be focusing. Sometimes we're wanting briefer treatments, and if a person's presentation isn't too severe, a briefer treatment may work that just uses common factors. So we've got some lists here of the things that across all treatments research has shown are the things that do work.
Sorry, Pip.
Yeah.
Just with that as well, what do you think is another factor, time? Because a lot of people want a quick fix, and a lot of agencies want that episodic.
Yeah, they do, don't they?
Yeah, so.
Yeah. The episodic model of care is a little bit difficult, I think, to think of. It's a really good question. My response to that is, if you are really, really, really constrained by the service, that you could do it. And in fact, Spectrum is doing this at the moment. We're working on some kind of trials of treatments that we're researching that are briefer. At the moment, we're doing a 10-week intensive group program. It's group only. There's no individual therapy. There's a little bit of individual support, but not really individual therapy. These are for the less severe presentations. This is like, from Spectrum's point of view, we're a tertiary service, we're a statewide service, so we do tend to see the more complex presentations, the people with more severe problems. So for Spectrum, the ones who aren't as severe can trial this 10-week intensive program. They are collecting some outcomes on that program, and they're seeing some good evidence in the early stages of this, and they're wanting to kind of roll that out in different area mental health services and trial it as well. So that's next year there'll be something published on that 10-week program. We're also going to trial an ACT program that is just done as a group model and over a limited time period as well. DBT has anyone bought, I didn't bring my books actually, but DBT has the new DBT manual that Marshall Linehan published in 2013, I think it was. Has anyone seen that manual? Yeah. So they have a schedule of different schedules of treatment in that manual. The standard one is a full year of treatment, but they have, I think, is it 12 weeks short treatments or even 6-week program for an inpatient unit. So the DBT does actually kind of have a plan for briefer period treatments of DBT. I'm not sure how, again, the more severe the presentation, the more intense the treatment is going to need to be. I think there needs to be an argument to present to services that for some people the episodic model of care is not going to work, because we have the opportunity, sure, we could treat them just from crisis to crisis, but they're just going to keep ending up in crisis. And if we do a sustained period of treatment over a year, then maybe that's going to get them free of crises. So it's actually an investment for the service. Yeah.
Actually, associated to this question, focusing on the models available for the treatment, like if Medicare provided 10 sessions or
right. Yeah.
Fixing these people, say, more vulnerable in terms of income, support, say, and all other things.
Yeah.
Affordability, to have a sort of year or 2 year sort of plans, and then. So where you see that, it's good to have a 12 weeks over a year or so, or more than 10 sessions.
Yeah.
And then nothing quick fix.
No. I know. We do talk about that, don't we, Rita, that the Medicare funded 10 sessions is not enough. I think services are going to have to find a way to respond to this problem. Spectrum will be trying to advocate politically for longer treatments, longer funded treatments. We don't know yet how the NDIS is going to support people with borderline personality disorder, but you're a bit doubtful about that.
That's really fine in drug and alcohol services. We kind of accumulate people with the more complex presentations and DPDs. We don't have a certain number of sessions that we have to work within.
Yeah.
So we do get a lot of people who could get their 10 sessions with a psychologist end up coming to us.
Yes.
Because we don't have to discharge within a certain amount of time.
Right.
Oh, we kind of found a loophole.
Right. Yeah, I think that's what you have to do. Find those loopholes. Medicare funded 10 sessions is never going to be enough. Not for someone with this degree of complexity and comorbidity. So I think referring to, can you refer to area mental health services to provide the treatment?
Yeah.
Yeah.
That's what we are doing at the moment. So, but again, how often the sessions runs, and then how often this person attend.
Yeah.
That also contributed.
I think that probably what's needed is to develop a specialty program that's unique to that group of people that can somehow manage if there's non-attendance I think there's room for a lot of work in motivating people and helping them to understand the benefits of this treatment, and maybe that's with the community at large rather than with individuals. I think there's a lot of room for growth in this area, and Spectrum is going to be advocating for more treatments as we go forward. Have you got anything to add to that, Rita?
Just that there may be another option. You can get 10 one-on-one Medicare sessions. You can also get 10 group sessions. So that could potentially be 20 sessions for the person.
Right.
If a
But the group is actually individual rather than...
Well, no, it would be part of a group. So
Right.
if the person has 10 individual sessions and 10 group sessions as part of a group, that's sort of 20 contacts. A psychiatrist, if that's appropriate, and some, pardon me, will bulk bill, that's potentially 50, is funded by Medicare. There's a mental health nurse, which is part of a number of practices, so that can be fairly regular contact as well. And sometimes if you can find a GP that is willing to actively listen to the person and maybe just listening to some, to actually actively work on a strategy and seeing the person every week for, say, 15 minutes, that also increases the amount of contact. So it's a little bit bits up, but there's by juggling the system a little bit, there is the potential that the person can get fairly regular contact with someone to help their mental health.
And for some people that would be helpful. For others, for people with quite severe borderline personality disorder, trust can be a real issue.
Yeah.
And developing confidence to even talk to a mental health clinician. Changing from different modalities and different time frames wouldn't suit a lot of people. It's kind of about that regularity, the reliability, and building trust over time. And that's where the gap is, I think. And services can be set up to provide those bitsy things, and it can look like we're doing enough, but the question has to be asked, are we really doing enough? And what do we need to really provide a treatment for these people? How important is this? But good questions. I'm sorry I don't have great answers for them. I wish I did. So there are therapist factors that are important. Self-reflection is important, isn't it? But supervision helps us to do self-reflection. Factors about the therapy, the collaborative approach, having consensus with the client on the goals that they want, no matter what treatment setting you're in, whether it's young people, whether it's asylum people, whether it's LGBTQI, no matter who it is, being clear with them on the goals of what they want and what you can help them with, and being clear on what you can't help them with as well, really helps at the start of treatment. That kind of honesty and then a collaborative approach. Focusing on change. I think there's two important qualities in treatment, two important factors. Despite all of the common factors that I've got listed, there are two fundamental important things. One is a relationship and the other is a plan. And you kind of need both. You can't just have a relationship, can you? If you're not kind of goal-oriented, if you don't have a sense that you're moving somewhere, you just have a nice relationship and nothing changes for the person. But equally, you can't just focus on a plan and say, okay, do this, this and this, which is what people sometimes get, without having that relationship that's attuned, that is repairing the invalidation from childhood, that is helping the person to understand how to make these changes in their lives. It's not going to work. I'm going to say a bit more about validation later on, so I'll come back to that. We have to be flexible with our clients as needed, appropriately, but also have some limits, like we have to know where we end and, where our work life ends and our personal life starts, or our tolerance to things that we're comfortable with and what we're not comfortable with. And just to be clear about those limits, we're allowed to do that. We don't have to put up with things that actually we're really, really uncomfortable with. And we don't, doing that for the sake of, trying to be gentle with the client, because it just doesn't work. We're real people, and actually having a real relationship with clients and letting them know that we're real people is actually really helpful. Letting them know that, I'm trying to think what I have limits on. I think I'm pretty flexible, actually. I'm not thinking of any at the moment. I know one of my colleagues struggles with people being late for sessions, so she'll have a 15-minute window for lateness, and if people come after 15 minutes, then they might as well not come. Whereas I don't care about that, actually. I'll give them as much time as I can until my next appointment. But there's nothing wrong with my therapist's limit on that, and there's nothing wrong with mine. These are just different. And as long as you've communicated that to the client in a reasonable way and said, this is just what I need to be working with you, then it works. It's fine. Does that make sense? And I think it's really important, isn't it? The questions that you're all asking about length of treatment. It's really important to have organisational support for what you're doing. It's really hard to be doing challenging work and to have personal needs around that if your organisation isn't supportive and doesn't allow you to have the time or the supervision or the training, and really just doesn't support the type of work you're doing. It becomes too stressful for the clinician. Working across teams, are you guys doing that? Spectrum where we can be involved with multiple teams, yeah. Working across services. There are multiple different services here in Australia providing different aspects of treatment, aren't there? And if you get the services not communicating with each other and working in different ways, it just ends up being a bit of a mess and really confusing for clients. So we try to kind of obviously work collaboratively across the different services involved. However, we tend to prefer a formulation rather than a diagnosis and use the formulation with the client to help them to understand their problems and then their treatment needs. And I'm going to come to risk a little bit later as well, so I'll focus on that later. So how do you incorporate these into our treatment? Willingness is important, upskilling therapists, supervision, and treatment plans. So this is fundamental in DBT, and I really like it. I come back to it all the time. The thing that we're heading towards is the client's version of a life worth living. Not our version, it's not what we think they should have, it's what they want. And but then, having the client's version of a life worth living, and then helping them to get there. Because quite often people have an idea of what they would like their life to be, but they don't even dare to think about it because they're so used to thinking they'll fail or they'll never get there. And then that ends up just kind of causing more emotional distress. So what we do is we'd say, well, okay, this is where you want to get to. We can help you. These are the steps you need to get there. DBT is particularly structured in that. So our aim is to help them to get closer to their goals, not to do anything else. Not at all. And in DBT we hold assumptions about clients. These just help with staying motivated. This is also a common factor, I think, that you have to have ways of having empathy for your clients in a continuous way. Somebody was saying before we started the session, talking about somebody riding a motorbike into the reception area at a particular setting. People can do all sorts of really challenging behaviours at times. And in order to maintain empathy for our clients despite those challenging behaviours, it can be really hard, can't it? So if you keep coming back to these assumptions, they're doing the best they can. They do have to try harder, but they are doing the best they can. They do want to improve. They have to learn new behaviour. We can't just tell them what to do. We actually have to help them to learn. I like the metaphor of the coach-athlete metaphor, where we're like the coach and our clients are like the athlete. We're there supporting them. We don't just say, okay, this is how you play football, go and do it. We're there on the sideline, cheering them on and saying, hey, but try doing this instead, You're actively involved, and it's a real relationship. But we do have to support them to learn new skills, not just expect them to be able to do it. And I do particularly like the last dot point. Our clients may not have, well, we kind of pretty much know they didn't originally cause their problems, but as adults, and I guess even as teenagers, to a degree, they are responsible for resolving those issues or working through them. Feel free to ask questions at any time. Okay, more about that. So, validation. I just want to spend, I've been talking about it quite a bit through the session. Why do we validate? As I said before, if we're just focusing on change all the time, that's actually can be quite dysregulating for clients. And also if we hold up the promise of something different for clients, or if we expect people to act in different ways, it's kind of invalidating to their sense of self, and that causes a real sense of discomfort. Like a personal example of this is I had got a really bad, I don't know what it was, a virus about a month ago, and I still have a little residual cough at the moment. I still get a little frog in my throat, but for about 2 weeks I just could not stop coughing, and I've never had anything like it in my life before. And I thought it was turning into asthma even, because at times I was finding it difficult to breathe. And my identity is I don't get sick, I never get sick. I came here and I haven't had a sick day for 2 years since I started at Spectrum. I hadn't had a sick day for 20 years in New Zealand before I came here. And people all around me get sick, and I get a little bit of a sense of it, but a couple of days later I'm better. And this is my identity, you know, I don't get sick, I don't take sick days. And here I was really sick, I was really unwell with this. I was a bit of a mess at work, and my colleagues were telling me to go home or to not come to work the next day. And I couldn't cope very well with it, because this isn't me, you know. It was really invalidating my sense of self. And I had to kind of slowly come to terms with, okay, who am I now that I can get sick, you know? What does this mean? Am I going to have asthma in an ongoing way or something, you know? And do I want this? Do I like this? It was actually really quite challenging. Now that's a really minor example, obviously, but if we're asking our clients to change their identity that they've held on to, or that they've had, or their lack of identity, sorry, that they've had from their development, and the ways that they've learned to manage that, it invalidates their sense of who they are, it invalidates what they know, you know. Doing something different is quite, it's opposite to your natural way of being, and as such it's an invalidation to yourself of who you are. Does that make sense? So it really is quite uncomfortable for people. It pushes them out of their comfort zone. That's why one of the reasons why people can seem quite resistant to changing. So that focus on change and invalidation of the, you know, do you find you have clients who say, I'm a really bad person? And you try to say, no, you're not a bad person. Are they going to believe you? No. So they've got their beliefs, and you know, if we try to change them, or if we act towards them in a way where we show we care, and they're not used to receiving as anyone caring for them, then it's challenging their beliefs about themselves, and that can cause quite a lot of arousal. And with that arousal, there's a sense of being out of control. They can't take on any new information, and in that arousal they can just kind of fall back onto the sort of old dysfunctional patterns. So the main reason for validation is to get arousal down. That's the main reason we do it. It works, doesn't it? If people had kind of varying experiences of validation working, that when somebody's with you and they're quite worked up, they're quite distressed, they're angry, whatever, or they're it's usually anger actually, or hurt, or a sense of injustice, and you just say, gosh, yeah, that actually, I can hear that you're really angry. I can actually really hear that, and I can see how you are. I can understand that would make me feel angry too. It just, you know, somebody gets them, and it settles that down a lot, hugely. Might not have resolved the problem why they got angry in the first place, but it gets the arousal down, And then, when the arousal is down, then you can do the work on learning new skills, and they can start to process new information. When they're aroused, they can't take in anything new. But validation does other things as well. It really strengthens your relationship with clients, doesn't it? We all need it, you know. This isn't just a clinical thing. Our social relationships are built on varying forms of validation. Our family relationships, you know, if you get home from work and people just say, you say, I've had a hard day, and your partner says, oh, so did I. I'm really, I've prepared the dinner, can you cook it, and then can you do the dishes because I've got some study to do. It's just very focused on action and not on validation, and it doesn't work very well, does it? So it's just a normal human thing, and we want to bring that human quality into our work with our clients. And it does help clients to stay in treatment. When it's really hard, validation can help them to keep going. I won't spend time on that, but I quite like the fact that in DBT there are 6 levels of validation, so you've got a whole lot of options. The first one is just staying awake, which actually isn't always, it's not just about staying awake, is it? It's actually about staying present and actually attending to what the client's saying and not kind of switching off. And from staying awake right down to radical genuineness, which is that real quality. Just using real language, not clinical language, just saying, yeah, I feel like that too, that really sucks. I say that quite often, that sucks. Because, you know, the reality of their lives, sometimes it does just suck. So, another thing I said I'd do in this session is talk about managing intense emotions. Again, I'll be leaning heavily on DBT for this. People familiar with some kind of arousal scale like this? Yeah, so there's zones of arousal. And the highest, that's in the highest arousal state, that's when you get just defaulting to the old automatic overlearnt behaviours, you know, those default things where you don't have to think. We all do it. If we're all in some kind of arousal state, that's when we all stop thinking and we do our default stuff, which might be a default style of communication, might be a default style of soothing ourselves with an extra glass of wine than what we should really have, or, you know, whatever. And obviously being too low in arousal is just not present enough, and we want people somewhere in the middle. So again, validation helps to bring people down so that we can work with them in a good arousal zone. So the strategies for decreasing arousal, as I've said, validation first. And then, I don't know if people want to talk about this. These are sort of particular skills that are detailed in DBT. Are people interested in talking about these a little bit? Or have any questions about any of these? Is anyone familiar with these? Familiar with, yeah? Yeah, so some of you are, yeah. So any questions about any of that?
What's improving the moment?
Right. I like that skill. In DBT we talk about all these things as skills, which is kind of a very sort of a concrete way of describing what they are. But I like it. What it is there's different ways of doing it, including from memory, using some imagery or prayer to help to improve the moment. But for me, as we teach clients to do this, it's just about, right now I feel really awful, everything feels like it's going wrong, and I'm just feeling awful inside. And I just stop and think about this moment. Okay, just this moment here, can I improve this moment? You know, here, right now, in this moment, can I improve it? Can I use something to make me feel better in this moment? It's quite a sort of a simple skill and quite, but in a way quite sophisticated as well, because it sort of takes a willingness to let go of, to be in the moment rather than in the whole picture of their distressing lives. So just, can I be in this moment, and can I use some imagery or some relaxation exercise, some visualization, or some meditation, or some soothing activity to improve the quality of this moment. Yeah, it's quite nice.
What's the tip skills?
The tip skills, T stands for temperature, I stands for intense exercise, and P stands for paced breathing or progressive muscle relaxation. So the three of these they're quite intense physiological skills designed to help change an intense physiological autonomic nervous system, sympathetic nervous system stress state. So if people are just really it's a kind of a crisis skill. If they're at almost crisis point, then we say use the tip skills.
Yeah.
So that might be the way we use temperature is cold shower, holding your head in a bowl of iced water, and not breathing, which activates the vagus nerve, the dive reflex in the vagus nerve, and activates the parasympathetic nervous system. Some people like to use hot temperature if they're feeling certain emotions, and that can change their emotional state as well. So a hot water bag, or just getting really warm with a heater and a weighted blanket. So varying ways of working with temperature. The intense exercise, that can be a problem. I've got various clients who can't do can't do much exercise. One's got an eating disorder and she can't exercise. The other's got a heart problem, and the other's got physical injuries that mean she can't do much at the moment. So that can be quite a hard one, but if they can do some form of exercise just to move the big muscles and release the stress chemicals, that can be a good thing. And then the paced breathing is a particular way of breathing it's not a really relaxing breathing method, it's a stronger breathing method where you breathe in for a count of 4 and breathe out for longer. I also actually commonly teach people the straw breathing method, if you're familiar with that. So breathing out as if you've got a straw in your mouth. You can actually do it with a straw in your mouth if it's a kind of a wide bore straw, but you can equally just purse your lips. So you're going, and it's quite a good strong breathing exercise if somebody's in a panic state. It's good for panic attacks. Or for anxiety, and just doing that in a strong way, and then over time, as they're doing it, they can regain control of their breathing, and then they can slow their breathing down. So these are kind of helping with intense emotions. The self-soothing, as I said at the beginning, one of the problems of growing in an invalidating environment is that people don't learn to self-soothe. And it's something that people aren't naturally born with, so it's something that we pick up as we go through our childhoods. So for a lot of our clients, have you noticed this, that they can have real difficulty with self-soothing? It's actually the last thing they feel like doing. It's so, they're much more inclined to be punishing themselves than soothing. So it can be really hard to get people to develop a good repertoire of self-soothing exercises other than medications or alcohol or excessive exercise or whatever. But there's a whole list of sensory things that we can be doing with people to help them to learn to self-soothe. And just, I sometimes sell these things as like a prescription. They may not feel like doing it, but they have to work on doing it, and they'll get better over time. Even though it's really counterintuitive to them, they kind of have to do it because it works.
And that's often the challenge, isn't it? People will say, I've tried that, doesn't work.
Yeah, they definitely do say that, yeah. But it might be the particular self-soothing thing that they try as well. Some people are not going to like a relaxing bath with scented candles. Different things definitely work for different people. So it is about exploring those. Deep tissue pressure is a really good thing. I think most people would respond to that unless they're very, very sensitive to touch. So if they can have some form of, a lot of the sensory modulation equipment is weighted to help with deep tissue pressure, but also massage or doing deep yoga stretches can help with that.
I find, because you said earlier that men tend to, generally speaking, tend to externalise. I find that with some guys that present with some of these things, that I like how you described the tip thing.
Yeah.
Because I do use physical activity a lot to try to distract them and get them motivated to do something physical.
Yeah. Yeah.
And that gets them a focus away
Yeah.
from
Yeah.
like a distraction.
think
but
that-
something
yeah.
physical,
Yeah.
like going for a really hard walk.
Yes.
As an
Yeah.
example.
Yeah. It is. It is a really good thing. I think exercise is good. It's good for all of us, isn't it? You know, like we often feel better, like we can get something out of us if we're doing some exercise. But if there people are in high distress, using the tip is good. And then it's kind of like emotion is like a wave, isn't it? It kind of rises and then it peaks and it falls. So as they're at the peak of the wave of emotion, and if they're feeling like they can't tolerate it, they would otherwise do something that's harmful. Well, at that peak, we want them to use the tip skills, the temperature or the intense exercise or the paced breathing. And then as they're calming down, we want them to use these other ones, distraction or self-soothing. Self-soothing doesn't work at the tip of the peak of emotion. It's just too soft, isn't it? That's when you use tip. But as they're coming down, the tip might have helped them to come down, but they're still not quite there. They're not quite returned to baseline. So that's when you could kind of add in, to then do some distract or do some self-soothe or do some improving the moment.
So,
Yeah,
sorry.
no, it's great.
So again with that, okay, you're working with decreasing the arousal
Yeah.
wave, right? But would you also at the same time try to identify the triggers when they get?
Only when they've come down,
Yeah,
because in the wave of arousal, well, you might be able to, but see, the first thing is that the client's not going to do these skills with you if you haven't validated first. If you don't have a validating relationship with them, so they have some sense of trust with you. So the first thing is to let them know you're with them, you get it, they're experiencing some real distress, you're listening, that sounds really hard. Let's think what we can do, because I want to help you with this. So you might say, just tell me quickly what's caused this, and it might help them to blurt something out. But it would be more of sort of a venting thing at that point. But then you'd work on the kind of strategies that help to de-escalate and calm down. And then when they're calm or afterwards, you might then look at, so what was going on? What happened? What went wrong? What could you do differently? That's what in DBT we call that a chain analysis, which I can talk more about. But yeah, when they're in the aroused state, their brain can't think much. I just want to add that people sometimes don't always want to use skills instead of medication. Valium can be quite nice, and why would I try something that takes so long and doesn't seem to work? People remember that film, Girl Interrupted? Okay, so this is some of the work. When people are in the high arousal state, that's when you use the distress tolerance skills to get the arousal down. When they're not in a high arousal state, you can do the psychoeducation around what's going on with emotion, and do the kind of education around emotion being like a wave, and if you ride the wave and let it pass, it does pass. Have you had clients experiencing that the wave passes? Yeah, they do agree with you, but it depends on how intense that wave is for them, whether they can ride it out and wait for it to pass. But what we're wanting to do is them to get more skillful, more resilient, more able to tolerate the stronger waves of emotion, so that they don't act in ways that are unhelpful, that they will ride it out, they'll see it will pass, and then hopefully they can do the work of saying, I'm pleased I did that, I'm proud of that, I'm really glad I didn't do whatever the other harmful behaviour would have been. And that builds a sense of self-competency over time as well. So we're trying to get them to recognise that there's a trigger, they react, they have all these interpretations and assumptions. We're trying to work on changing their assumptions. We get them to recognise the internal physiological changes, so they can also work on those. They can slow their breathing down. They can change their posture. They can splash water on their face to change their temperature. But then when they're experiencing the emotion, with every emotion there's an urge, isn't there? With every emotion there's some urge to act in some way. And there's different urges with different emotions. I quite like to ask this: what's the urge that goes with the emotion of guilt? What's the urge with guilt? What are we prompted to do when we feel guilty? Pardon?
Shame.
So what I'm going to do is that's actually a separate emotion, you see. So with guilt, what do? You know, I feel guilty, I need to...
Compensate.
Yeah. Compensate, apologise, repair. But with shame, when I feel shame, what's the urge to do? Withdraw, hide. So it's I kind of find that a good way of differentiating between shame and guilt, because often people can't. But the urges are actually very different. And with guilt, you know, if there is an emotion of guilt, and what we're doing in treatment is helping them to figure out, is there a reason, you know, is the guilt justified? Have you done something that warrants guilt? If you have, then you do repair it, you know, because we all make mistakes. I'm repairing and apologising all the time. But we do it, and then we try to move on from that. We let it go. Because a lot of our people get stuck with the guilt. They can never get a sense of having repaired enough. And that can take quite a lot of hard work as well. But with these urges that go with emotions, we're wanting people to learn to recognise the urge and slow down the interval between urge and action. Initially, people don't realise there is any time there, do they? It's all so quick, like from 0 to 10, and from 0 to 10 to action immediately. But we're trying to slow it down. So the emotion escalates, they can feel all the body changes, the physical changes, and then they feel the urge, and before they act on it, they've got some time. They can buy time. They can use some, you know, the tip skills or some emergency strategy to stop them acting. So they increase the gap between urge and action and put different things in there that stop them doing the actions that they might later regret. And when they do it, if they do opposite action, they're gaining skills, they feel better about themselves, they're getting more positive emotion from that. If they act on the urge, it just tends to compound their problems, and it re-triggers more emotion, and they just stay in that cycle. So there's a lot of education in there for clients. And these are the strategies we use: understanding emotions as being like a wave, surfing the urge of emotion. Okay. I've mentioned mindfulness there and quite a bit, so mindfulness is very common now, isn't it? Most people have exposure to mindfulness in various ways, in various settings. I've repeated in the present moment twice there, I see. But that's just a nice simple definition of mindfulness. And in DBT, mindfulness is taught in terms of the overlapping circles of emotion, mind, wise mind, rational mind. It's a good way of kind of teaching mindfulness in DBT, because clients can actually recognise that they're in an emotion mind state, and is that, you know, helpful for them? Can they get into a wise mind state? And when they're feeling kind of confused and not sure what decisions to make, or hurt, or quite emotional, just even recognising that it's emotion mind can be helpful, and that there is the option of trying to find wise mind and get into a state where they're more reflective about what's going on for them and not so caught up in the emotion of it. I could spend a lot of time talking about DBT, but that's not what I'm really here for today. So just briefly on managing risk. Do people feel that they have knowledge and competence in the areas of managing risk with personality disorder, borderline personality disorder?
Can never be enough, isn't it?
Pardon?
Can never be enough.
Can never be
knowledge.
enough, yeah. It's a challenging area, isn't it? It really is. But there are the general principles, definitely separating out the acute and chronic risk. Most of the risk that we see with borderline personality disorder, of course, is chronic. It's just that repetitive response to life's difficulties. Sometimes it can seem to escalate, and we might think that it's become acute, but actually it's usually just perhaps a more intense variation of the chronic pattern. Acute risk with borderline personality disorder is usually associated with some quite serious life changes, like particularly major losses. If there's a major loss in a person's life, then that's when I would be definitely more alert to needing to respond differently to their kind of risk communications. It's usually the main factor. Yeah. There are guidelines for managing risk of people. This is very accessible, isn't it? The MHPN guidelines. They have quite a good section, guidelines for managing risk. They borrow from some of the spectrum stuff there, actually. And then, sorry, that's supposed to be focused on events leading up to the risky behaviour. So that's the chain analysis that I mentioned to you before. The chain analysis is just when the person has got through the risky state and they're calm again, do a step-by-step analysis of what led up to that risky behaviour and work with them on different ways of intervening at each little step. Like the whole problem itself can just seem too hard to change, but if you break it down into little pieces, you can work on all the little pieces. Many people use chain analysis here. Quite a few heads nodding. I'm not going to focus on it. Just going to go to this one now. Self-care. What ways do you use to look after yourself? What ways do people in this room use to look after yourself?
Value.
Okay, great. Yep, I really like that one. What other ways?
Have a massage.
Massage? Yeah.
Dog gets a workout.
Yeah, I use that as well. Come on, you will have a walk tonight, even if you don't feel like it.
I'll throw the ball, he brings it back.
Oh,
That's
right.
yes. He brings it back.
Other ways?
Debriefing.
Debriefing, yeah. I like to do that too, just talking really helps, doesn't it? Anything else?
Keeping the weekends ready for myself.
Great,
After
well
work
done.
hours as well sometimes.
Yeah.
Really can be
Yeah.
for myself.
Yeah. In sessions, how do you manage yourself in sessions? If they're hard, they can be difficult sometimes, can't they? How do you manage yourself in session?
We were talking about this just on the way in, about those clients that sometimes put you to sleep or you feel very fatigued.
Yeah.
It's almost like a wave
Yeah.
of fatigue coming over you.
Yeah.
And other
Yeah.
clients are almost very stimulating and wake you
Yeah.
up and
Yeah.
energise you.
Yeah. Yeah.
So
Yeah.
just maybe doing something with your body
Yeah.
in those situations.
Yeah.
Moving in the room
Yeah,
if you
good
can.
point. Yeah, but the first point to that is being aware of it, isn't it? Being aware of yourself. So yeah, being tuned into yourself, mindful of your own responses. Yeah, that's great. Any other ways that you look after yourself in session?
I think, because I do a fair bit of outreach as well, that
Yeah.
you need a form of structure.
Yeah,
Because that's,
Yeah.
that could be a saver.
yeah,
you know,
totally.
so-
Yeah, I think that's absolutely true. I think because I actually think we all need structure. Our clients need it, and we all need it as well, don't we? It sort of kind of helps us to keep going, to sort of not get lost in what can be really difficult and challenging stuff.
Yeah, structure's good. I think just also constantly assessing where I'm at, because sometimes I feel like you can get too involved,
Yeah,
and then you kind of go take a step back and look holistically,
Yeah.
having trust in
Yeah.
the client,
yeah,
that they also, like maybe you're like, I don't know what to do, and then having
Yeah.
trust that
Yeah.
maybe they'll know what to do.
yeah. And that you don't have to know what to
Yeah.
do either. That's actually the beauty. I thank you for bringing that up, because I haven't said this, but I think there's been times when I've thought I should know what to do, probably when I was less experienced. But now I don't, I can just be in the room with someone. Actually, that's the most therapeutic thing, is being alongside people. We don't know what to do a lot of the time. We don't know what's right. We don't know if our treatments really are the right treatments, but there's a good rationale for doing what we do, and so we can sit with that. But just, saying, gee, this is really hard, that can be enough.
It's a validation.
It's the
as well.
validation, yeah. This is really hard. I don't know what I'd do if I was in your position. Sometimes I've actually said, what I had done when I was in a position like that was this, but I don't know if that's right for you. You're not telling them to do it, you're just kind of giving them, you're just modelling how people deal with problems which they didn't learn when they were young. That's great. Any other ways? I think we have to take care of ourselves. We really do. Like, seriously, this is important. This is hard work. There are huge risks of burnout in working with people either with BPD or traits or even just complex, challenging presentations. The addiction area can be really challenging. Every area that you work in can be really challenging. The organisation isn't actually going to do that good a job of taking care of us. We have to be mindful ourselves, and we have to seek out supervision or whatever we need in the way of mentoring at work. But the first thing is to be aware of your own state. Be aware of how you're going. Are you getting a bit stressed? Are you taking on too much? Here am I talking. I need to walk the talk, don't I? So mindfulness of your own needs. I heard someone coin this phrase kindfulness, which I quite liked. So that's kind of mindfully being aware of yourself and being kind to yourself. We want to teach our clients that. I'm forever trying to teach clients to have compassion for themselves. But we also need to be kind to ourselves, because it can be easy at work to get a little bit self-critical or a little bit self-doubting. Or just think we're not doing enough or not quick enough, or there can be various ways that we're not that kind to ourselves. And we need to bring kindness, keep kindness in our work to ourselves as well as to other people. And supervision. Okay. I think that's my presentation.